Good morning, everyone. My name is Rosa Reyes. I'm a nurse practitioner for the Acute and Transitional Pain Service at South Health Campus in Calgary, Alberta. My topic for this morning is managing acute post-operative pain. I would first like to recognize that my work takes place on historical and contemporary Indigenous lands, including the territories of Treaties 6, 7, and 8, and the homeland of the Métis. I also acknowledge the many Indigenous communities that have been forged in urban centres across Canada. I have no financial disclosures or affiliations. For learning objectives, I'm hoping that the audience will be able to have a better understanding of acute post-surgical pain and how to address and manage this type of pain, and hopefully decrease the risk of developing chronic post-surgical pain. I'd also like to briefly go through possible pharmacological and non-pharmacological modalities in managing post-operative pain. So first of all, what is pain? So according to the International Association for the Study of Pain, it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Specifically, acute pain increases the nervous system activity, causing increased pain in a generally time-limited period. This is most often obviously caused by some type of injury, surgery, traumatic event, or painful medical procedure. This type of pain is short-lived and should only last approximately 3 to 6 months. The pain should decrease in intensity as well as resolve and heal at the injured affected site within that time period. Primary goal of treating this type of pain is to facilitate recovery and prevent chronic post-surgical pain or chronic pain in general. Why we address post-operative pain, acute post-operative pain, because even though it's a natural phenomenon, basic science research has demonstrated that as early as 20 minutes after the onset of tissue damage causing persistent pain, neurochemical and structural changes begin to take place in the body's pain pathways. In the transition from acute to chronic pain, these changes can become hardwired into the pain switchboard. And these are located in the dorsal horn of the spinal cord and in the higher CNS centers. The net result being an increase in the frequency and intensity of pain signals transmitted to the brain. As you can see from this table, acute pain most often affects pretty much every system of a patient. From a pain perspective, we know that due to neuroplasticity, poorly treated acute pain can lead to chronic pain. Leading into what we call chronic post-surgical pain. Chronic post-surgical or post-traumatic pain is defined as chronic pain that develops or increases in intensity after a surgical procedure or a tissue injury, and this persists beyond the usual healing time of at least 3 months. Some risk factors that have been identified that increase the risk of a patient developing chronic post-surgical pain is the presence and intensity of preoperative chronic pain, also the intensity of acute post-operative pain, and also the time spent in severe pain after surgery. Another risk factor is higher consumption of post-operative analgesics, most often related to opioids. And thirdly, negative cognitive affective states, including perioperative depression, anxiety, pain catastrophizing, and post-traumatic stress symptoms will heighten their risk factors as well. And finally, there is a prevalence of of about 25% with preoperative opioid use that may lead to opioid-induced hyperalgesia. Prevalence of chronic post-surgical pain is often quite high, especially even after 12 to 18 months from that type of surgery. Specifically, if you look at phantom limb pain, there's a high risk of developing this type of pain by about 77% at the 12-month mark. Elective surgeries, such as total knee and hip replacements, can range from 12.5 to 28.1% of developing chronic post-surgical pain at 12 to 18 months. So what can we do? First of all, let's go through the pharmacological modalities in managing this type of pain. And most often, our approach is from a multimodal perspective. That may involve parenteral infusions and as well as regional anesthesia. When we say multimodal, we say that there's many types of receptors, pain receptors, channels in our bodies that can help address multiple sites of pain. This diagram shows you that we can look at it from the peripheral as well as the central types of nociceptors. Our first line, of course, is usually acetaminophen, as long as it's not contraindicated. Mechanism still remains unknown, but it is classified as an analgesic and antipyretic. It is often used with a non-steroidal anti-inflammatory drug, and these are quite effective for mild to moderate pain. When combined with opioids, it may actually decrease the use of the opioids by about 20 to 30%. We of course need to be quite cautious with somebody with underlying hepatic or renal dysfunction, as well as in the elderly. We usually recommend a maximum of 2,000 to 3,000 milligrams for the elderly population. But for otherwise healthy patients, a maximum of 4,000 milligrams per day is adequate. Keeping in mind this is for treating acute post-operative pain, that we would recommend it for quite a short, brief period of up to 7 days, possibly up to 14 days. Next line, in use with Tylenol, we often would recommend a non-steroidal anti-inflammatory. This helps with the suppression of the prostaglandin synthesis, causing an analgesic, anti-inflammatory, and antipyretic response. This again may help in reducing a patient's opioid requirements postoperatively. Again, considered to be safe with short term, mostly recommended for about 3 to 5 day courses, but also be cautious with underlying hepatic, renal, or cardiac dysfunction, as well as anyone with a risk of GI bleeds or coagulopathy. And of course, opioids. Short term can be quite effective for acute post-surgical pain. And when we say short term, we would recommend the smallest doses of any of these opioids of morphine, oxycodone, hydromorphone within a few days, up to a couple of weeks. We also advise that patients to taper gradually off their use of the opioids as well. Adjuvants also play a part in the multimodal analgesic approach, particularly with patients that may develop neuropathic or nerve pain. There are times when the use of the following medications may alleviate this type of pain, and the first lines are usually considered to be anticonvulsants, or other well known as gabapentin or pregabalin. The second line is usually antidepressants, such as amitriptyline or triptyline, which are tricyclic antidepressants. But we also have seen that SNRIs and SSRIs can be also quite beneficial. Other options are cannabinoids, but we're talking about the synthetic version that is on formulary called nabilone. Other options, of course, would be sodium channel blockers like lidocaine infusions, muscle relaxants, that would be cyclobenzaprine or baclofen or methocarbamol. As well as alpha-2 adrenergic agonists, specifically clonidine, which may help with some types of persistent pain syndromes. In addition, there's always a consideration that we could offer patients who are on quite high doses of preoperative opioids, and we would like to decrease their risk of developing opioid-induced hyperalgesia. We may offer one of these infusions or both of these infusions, depending on how they are doing postoperatively. Low-dose ketamine is an N-methyl deaspartate receptor antagonist, blocking glutamic acid and in turn producing an analgesic effect by suppressing and changing the heightened central sensitization caused by postoperative pain. This reduces the polysynaptic spinal reflex. However, it may produce a dissociative state. Another option would be lidocaine, which is a sodium channel blocker that would be used systemically as a local anesthetic, also used as an antiarrhythmic for cardiac patients. Lidocaine given systemically may decrease peripheral and central sensitization. Lidocaine may also add a benefit of a faster return to bowel function for patients undergoing open or laparoscopic abdominal surgery. There have been studies that show that lidocaine has reduced opioid consumption by up to 85% in comparison with a control group. And other options are regional anesthesia, specifically neuraxials, epidurals, and spinals, as well as quite a prevalent intervention at the South Health campus, especially for our elective knee and hip replacements, is offering them either a single shot peripheral nerve block or a continuous peripheral nerve block infusion. This is all done by the anesthesiologist under ultrasound, in which a local anesthetic, most often bupivacaine of 0.25%, along with dexamethasone and epinephrine, that is specifically injected into a specific region of the body that would help provide temporary pain control in hopes of reducing their opioid requirements post-operatively. Main example for this is the use of an adductor canal block, which would direct lower pain, actually no pain, and less sensation to the affected knee, but does not inhibit their motor power. These patients have the ability to mobilize as a post-op day zero. Some recent examples of some studies that have shown that multimodal approach has been quite effective. One in particular is the gabapentinoids and acetaminophen for managing postoperative pain. This was looking at 14 studies that were included and were all randomized controlled trials evaluating postoperative pain. There was a total of 1,160 total patients in the systematic review. And surgeries that were included were breast surgery, urology, orthopedics, oral, gynecologic, thoracic, cardiac, and general surgeries. Out of the 14, 9 studies were included in the review. About 64% reported an improvement in pain scores, a reduction in the use of supplemental rescue opioids for the treatment of pain when in combination with gabapentinoids and acetaminophen. Another example was reducing the opioid usage in total knee replacements, which looked at non-opioid pharmacological therapies including 𝐒𝐔𝐁 inhibitors, also known as 𝐒𝐔𝐁𝐄, corticosteroids, acetaminophen, ketamine, pregabalin, and duloxetine. The main outcomes they were analyzing were the effect of these different approaches on pain reduction, along with the use of an adductor canal block in targeting the sensory branch of the saphenous nerve, medial cutaneous femoral nerve, nerve to vastus medialis, and the articular branches of the obturator nerve. This again had a better preservation of the quadricep muscle and improving postoperative mobility. A newer intervention that was mentioned was cooled radiofrequency ablation and peripheral nerve stimulation. I've yet to see this so far, but stay tuned. I think it's coming soon. And the other one for pain management after shoulder arthroplasty showed a total of 12 randomized controlled trials showing that single-shot nerve blocks and continuous infusions did offer greater pain relief in the immediate postoperative period. And this was in comparison to local infiltration of the joint itself. Non-pharmacological modalities that could initially help treat acute pain could include a combination of the following. The main ones that of course we see in acute care facilities is rest, elevation, physiotherapy, ice therapy, but there's other modalities that could be offered, conditioning, TENS machine, other things that I know that we're trying to address and assist with in the transitional pain clinic would involve the psychological perspective, involving acceptance and commitment therapy, as well as mindfulness meditation. And there are other non-pharmacological interventions too, such as trigger point injections, prolotherapy, and as I mentioned before, RF ablation. some newer articles looking at the effects of non-pharmacological interventions. One showed the use of music and music could significantly relieve post-operative pain. Also, providing pre-operative education on the safe use of opioids in managing pain for orthopedic patients showed a 44% decrease in opioid use. And the one that we're seeing a lot more, and I know is being currently studied at one of the other sites in the Calgary zone, is virtual reality, specifically for people going through surgery as well as extensive, complex, and painful dressing changes. This recent study showed that 8 randomized controlled trials enrolling 723 participants applying virtual reality relieved post-operative pain effectively, as well as lowered post-operative pain scores in comparison to a control group. Some other resources that may be quite helpful in managing post-operative pain, specifically in prescribing opioids. There's quite a lot of helpful guidelines out there. These are the ones that are that have been found to be quite beneficial. First article offers guidelines on how to safely prescribe pain medications for discharge after an elective surgery. The second one is a web link to the California Society of Anesthesiologists on managing pain after surgery. The third link is to Michigan Open, which stands for Opioid Prescribing Engagement Network, and this one provides really great resources related to pain and opioid management. And the fourth is to the ASRA, or American Society of Regional Anesthesia, and they have compiled resources in also helping managing post-operative pain. I also like to give a little shout out for our transitional pain service, and fortunately we have it at South Health Campus, and unfortunately it is not available anywhere else as of yet, but I'm hearing down the pipeline that we are trying to offer this throughout the whole Calgary zone. And the Chronic Pain Center continues to still see patients based on referrals from patients' family physicians or healthcare providers. That's all I have for now. Thank you for listening, and I think we're going to be going through questions and answer period after the presentations. Thank you.